Good morning, everyone, and welcome to today's webinar, Past, Present, and Future, the Story of a Northern Ontario First Nations Health Data Partnership. My name is Donna Atkinson, and I am the Research and Operations Manager at the National Collaborating Centre for Indigenous Health, and I'm joining today from the traditional territory of the Lheidli First Nation in Prince George, BC. I'm also co-moderating today's webinar along with Christina Villalobos, and I'm just going to turn it over to her briefly to introduce herself.
Thanks so much, Donna. Welcome, everybody. My name is Christina Villalobos. I'm of Settler Creek ancestry, and I live in the Robinson-Huron Treaty Territory and the traditional lands of the Atikamekshik, Anishinaabeg, and Wahnapitae First Nations, and also known as Sudbury. I support Mamow Ahyamowen as a project manager, and we're really grateful that you are giving us your gift of time today to join us in this webinar.
Great, thanks, Christina. Okay, so before we begin, just very briefly, for those of you not familiar with the Collaborating Centre for Indigenous Health, we are one of 6 national collaborating centres established across the country with funding from the Public Health Agency of Canada. We were established in 2005. We have sister NCCs across the country focused on different topic areas, including infectious diseases, environmental health, healthy public policy, determinants of health, and methods and tools for knowledge translation. And the NCCIH is unique in that we are the only NCC that's focused on the health of a population. So our center supports health equity for First Nations, Inuit, and Métis people by promoting the use of Indigenous informed evidence to transform practice, policy, and program decision-making across all sectors of public health. Just a few housekeeping details. So all questions for panelists, as well as any technical questions you might have, you can submit in the Q&A window, and you should be able to find that at the bottom of your screen. Links to resources mentioned by the speakers will be posted in the chat window for everyone to have access to. Today's webinar is being recorded and will be available on the NCCIH website. And just to note that there's going to be some brief pauses in between presenters, just as we deal with our technology on our end. Okay, so learning objectives for today, we're going to explore this partnership as an example of First Nations leadership in Indigenous data sovereignty, highlight the variation in mortality-related health inequities experienced by First Nations communities in Northern Ontario, and recognize the importance of meaningful knowledge translation in supporting self-determination. So we have 3 wonderful presenters today, and I am going to turn it over to them to introduce themselves.
Hi, everyone. Thanks so much. I'll just take a minute to share our slides here, and then we'll do our introductions if that works, Donna. All right, does that look good, Donna?
Yep, sure does.
Okay, thanks for confirming. Just want to make sure we're starting off on the right foot. So first off, just want to say it's our great pleasure to be here with you all today. Chimigwech, thank you so much to folks at the National Collaborating Centre for inviting us to share the story of Mamow Ahyamowen, which we'll learn more about in a couple of minutes. And we do want to take a moment to introduce ourselves in accordance with the protocols of our nations and communities. So I'll start here, and then I'll hand it over to my lovely co-presenters. So bonjour, Nindinoe Maganak, Maureen Nindishnika Jaganashima, Iwakan Manidogishigot Nindishnikas, Gojijignishnakadi Ishkonigan, Awin Mashi Ninjkinamasi Ninduda, Miigwich Bisandawiag. So for folks who know Anishinaabe, you might have understood what I shared, but also my language skills are very basic. So I'll share what I said in English as well. My English name is Maureen. I'm from Couchiching First Nation, which is in Treaty 3 territory, Northwestern Ontario. I grew up nearby in a small town called Fort Frances. I don't know my clan. And for folks who know people in the area or who are from the area, my mom's name is Joanne. My grandma's name was Phyllis McPherson, and my great-grandparents were Mary and George McPherson. So I'm privileged to serve Mamow Ahyamowen as a knowledge translation specialist, which essentially means it's my job to help ensure that our work is shared in an effective, meaningful, and culturally appropriate way. But we'll get more into that a bit later. For now, I'm going to hand it off to my co-presenter, Loretta, to introduce herself.
Waje everyone. Hello, my name is Loretta Loon, and I'm from the traditional territory of James Bay along the western coast in the community of Moosonee, Ontario. I am Innu and EU Cree, and my relations are from EU Istchi, which is in northern Quebec, and the meaning of the word is known as the People's Land. I'm the daughter of 2 Cree parents, and I'm affiliated with Fort Albany First Nation and a clan council representative of Quebec Council based in Moose Factory. My father and our descendants are from the northern Quebec community of Waskaganish, and we speak the Y dialect, and my mother's descendants are from the communities of Moosonee and Moose Factory of Ontario. I also want to say Miigwech to my colleagues who are here today, and to all of you for taking the time for being on this webinar. Miigwech.
Hello, everyone. I'm Jen Walker, and I come from the waters of Julia Candlish, who comes from the waters of Margaret Jessie Londo, who comes from the waters of Helen Marcella Newhouse. I'm a member of the Six Nations of the Grand River, and I'm an associate professor at McMaster University and an epidemiologist. And I am really happy to be here and to be presenting with my co-panelists.
Thanks, everyone. I think now we're ready to get started. I think Jen's going to share a high-level outline of our presentation, and then we'll dive into things. So Jen, feel free to take it away.
All right, thanks, Maureen. So we're gonna give a little bit of an overview of Mamow Ahyamowen and the background of the partnership and where it came from. Talk a little bit about the data that we've used in the work we've done and the data linkage process. I introduce you to the report, one of the big reports that we've been able to achieve so far, which is a Learning from Our Ancestors report. Talk about our process and goals around knowledge sharing and impact and our next steps. So in terms of the background for Mamow Ahyamowen, we're talking about it as the partnership. It was formed as a collaboration between First Nations health and social service organizations that serve communities, First Nation communities in Northern Ontario. Some of them also serve a broader like base of people beyond First Nation communities. Some serve people in sort of more diverse urban settings, but all serving Indigenous communities. We're referring to it colloquially as the partnership. We've always talked about it as the partnership. And we formed this, I shouldn't say we actually, I've been sort of alongside of the partnership that formed in 2016. So it was formed by these health service organizations, health and social service organizations that shared a need for high quality community specific health data to help inform decision making and next steps. So it wasn't, it really was a venture that was driven by the partners that formed that partnership. Their first gathering, they were, and like when they started, it was called the First Nations Center for Excellence in Epidemiology. And as a First Nations epidemiologist, I was quite excited by this. And so was invited to come and listen to the conversations. And so it really wasn't an academic venture. It really was something that this partnership has now reached out to people with different skills, with different data, with different knowledge to help them in their goal for high quality community specific health data. pass on to Loretta now to talk a bit about the partnership background.
So this slide depicts the image of since 2016, Mamow Ahyamowen has grown to include these 11 organizations that you see here. And I'm here today to speak on behalf of the Winnebago Area Health Authority, or WAHA. So there are 78 communities across Northern Ontario. And in the next slide, you'll see a map to get a better picture of it. So these organizations are a blend of health authorities and tribal councils, and they work together to reach common goals and interests. So the partnership, it's not a legal entity, and we'll come to that on the next slide. Thank you. Next slide. So as mentioned, Mamow Ahyamowen serves 78 communities, and you can see the sparse geographic image here. It includes communities from Ontario and Quebec, the border, James and Hudson Bay coast, and across to communities through the Manitoba border, as you can see. So early on, Mamow Ahyamowen decided that it wanted the voice to be in Northern Ontario focused, and decided that it would only include communities as far south as those along the north shore of Georgian Bay, or Sudbury and Sault Ste. Marie. This is because the needs of the communities in the northern part of the province are unique compared to those in the southern part. As an example, most of the year, many of our communities are only accessible by plane, or they have ice roads. In the context of James Bay, we are only accessible by air and winter road. There's no roads in Moosonee, so again, that's only accessible by plane and train, which is the Ontario Northland train. And next slide, please. And this is a site map of Western Europe. So if you can examine the context of James Bay and our other communities in the Northwest, you can sort of get an idea of the context of this. And an appreciation of the geography. And there might be some similarities to Northern Ontario. So it's important to note that the needs of the people within the communities or the various regions are unique and different. Next slide. Thank you.
Thanks so much, Loretta. Just want to talk a little bit about the partnership's governance briefly. So the partnership's not a legal entity, as my co-presenters mentioned, and it's governed by a steering committee that's made up of 2 representatives from each partner, and the group uses consensus to make decisions. So for those of you who are familiar with the constellation model of collaborative social change, that would be a good description as to how our group works. Unfortunately, we don't have tons of time to get into what exactly that means, but just a reference point for folks who might know. So in this aspect, the partnership keeps the partners and steering committee members at the forefront and stays focused on action. Essentially, in this context, the constellation model is bringing together steering committee members to work toward a joint outcome. And again, the focus is really on action and inclusion. Again, as Jen said, this was primarily motivated by the partners in our region. It wasn't necessarily an academic venture, although we have received a lot of support from our academic partners. So now you know about why we came together, who's involved, and how the governance works, but I'm sure you're wondering something like, okay, well, what do you guys actually do? Which is a very valid question. So we work with communities and partners to find, analyze, and interpret data in response to questions that they've prioritized, following a culturally respectful path. And we're going to break down this kind of statement throughout the next couple of slides. So the first thing we could break down from that statement is the word data itself. So the word data is actually a plural form of the singular noun datum, which really just means a piece of information. When we bring more than one piece of information together, it becomes data, plural, and we can then use those pieces of information for reference or for analysis. So in other words, we use them to better understand something we might have questions about. So we can use something like the weather as an example. This morning it was around maybe 5 degrees in Thunder Bay. It's getting chillier as we're moving into the fall. Tomorrow, I think it's supposed to be about the same. And we could go on throughout the week and talk about what it's supposed to be like on Friday. But the point is, when we collect the average temperatures for the week, maybe for the month of October, and even think about what the average temperature of October is throughout the years or across the years, they can help us to understand weather patterns and make predictions about weather for the future, those pieces of information, right? So this is actually something that our ancestors used to do. And some folks do still do that, right? They may not have measured the temperature on a Celsius or a Fahrenheit scale, but they had their own ways of collecting data about the weather to inform their decisions about daily life. As many of you will know, there are various types of data. We work primarily with quantitative data. And within that kind of umbrella, we work with administrative data, which is basically any form of personal information that was originally collected for another purpose. So for us, it's usually health administrative data or data that was originally collected within the healthcare system. So every time you interact with the healthcare system, so anything from going to the doctor, going to the ER, or getting a blood test, somebody records information about that somewhere. We'll get more into what that actually looks like later, but we use health administrative data in the work that we do because partners and communities have told us that they want to know what kind of data about us is already out there rather than collecting new data, which is a very, very important thing that a lot of our research partners do. But this is what we're focusing on for now at their direction. A little more about healthcare administrative data in Ontario. Here in this province, there's an independent nonprofit corporation that collects health administrative data called ICES. You may have heard of ICES being referred to as the Institute for Clinical Evaluative Sciences, which is their former name. So the folks at ICES use health administrative data to monitor and evaluate our health system. They're allowed to do this because they're designated as a prescribed entity under Ontario's Personal Health Information Protection Act. So they do have to adhere to some fairly strict rules about privacy and such. But I'm actually going to hand it over to Jen, who's going to tell us more about ICES in the context of First Nations health data, because she plays an important role in leading that work.
So yes, one of the roles that I do play is as I have been for a while now, the Indigenous lead and a scientist at ICES. So we can use these health administrative databases and they all link together with key numbers. And then, really trying to open that up and make sure that any First Nations data, that the data are available to First Nations to be able to make decisions and inform knowledge about First Nations. So, those principles of ownership, control, access, and possession are embedded in the way we're thinking about this. So those health administrative data at ICES combined with strong data governance agreements and relationships, but formalized data governance agreements that sort of articulate how we are going to ensure that First Nations will own, control, access, and to the greatest extent possible possess the data that sits at ICES. And then what that has enabled is actually the bringing in of the Federal Indian Register, which was the choice of the Chiefs of Ontario to unlock those health administrative data so that we knew who in the administrative data were First Nations people. So of course, there's limitations to this. We only have, we're using a colonial definition of who First Nations people are. but it has enabled us to create a data set that is this database of it's not quite 200,000. It's somewhere between 150 and 200,000 individuals that reside in Ontario who can be identified as a First Nation person. And unlocking that really required like a few stages of data, of the Chiefs of Ontario asserting data governance. And so, beneath this final data governance agreement that actually was established in 2012, so we're 10 years into this agreement, there were other sort of resolutions and decisions that were made by Chiefs of Ontario and by Chiefs Committee on Health that were sort of telling ICES that we needed to be responsive as an institution or as an organization. We needed to be responsive, and we needed to understand First Nations ownership, control, access, and possession of the data that were held at ICES, culminating in a data governance agreement that we've been working with for the past 10 years. And we talk about this here. There's a lot more detail we could go into, but talk about it here because if it helps to form the foundation on which Mamow Ahyamowen could use data and access data. So this Chiefs of Ontario ICES collaboration enabled the linkage of that federal Indian register. That enables Ontario-wide projects to be done for all the First Nations identified individuals living in Ontario, but also community projects everywhere from community level up to Ontario-wide. And Mamow Ahyamowen sort of, in the middle because just serving the First Nation communities in the north. We also make sure that what's articulated in those data governance agreements are backed up with processes and policies and tons of procedures. So there is a First Nations Data Governance Committee that reviews researcher-driven, community-engaged projects and assesses them. Also, communities have access to, there's a funding pot where they can ask questions and analysis can be done so they can have their own results. And we have in this collaboration secondments right now. Someone from Chiefs of Ontario is seconded to ICES, and we've had it the other way around. And just you can see up there the images of many of the reports that have been some of the reports that have been generated and visuals using these linkages so far.
Thanks so much, Jen. I think Jen just did a really great job of talking about the overall landscape of First Nations health data at ICES. And I'm going to just focus for a few minutes on that linkage process that she talked about, because it can be fairly abstract for folks who aren't familiar with this kind of work. I know it definitely was for me when I first started in my support role at the partnership. So when partners and communities have questions about the health of their people, again, Jen talked about them working with ICES, using that process to figure out what kind of health administrative data is out there that relates to their question. And you see that up on the slide here. There are various health administrative databases that folks at ICES are able to pull from, depending on the health topic in question. Then what happens is they link this data to data from the Indian registry system, which again is maintained by Indigenous Services Canada. So the IRS, as we sometimes refer to it, or Indian registry system, has personal and demographic information about all registered status Indians in Canada, as Jen said. And once these databases are linked, any information that could be used to identify people, like their names, their health card numbers, their status numbers, are removed. So I'm a status Indian. No one analyzing the data is going to be able to say or see that Maureen Gustafson went to the doctor for stomach pain on September 10th or whatever. We don't get that level of detail, just to reassure folks who might be a little bit worried about privacy. Everyone's assigned a unique identifier to maintain that linkage. So once the databases are linked, we can find people from our communities who are in both data sets to learn more about their health, and then answer the questions that communities and partners have brought forward. So far, we've done one project in this way. The focus was on the health of people from Mamow Ahyamowen communities who passed away between the years of 1992 and 2014. The steering committee decided to focus on this particular topic because it was broad and would allow them to explore a lot of different health kind of topics or issues before deciding what to zero in on. So even though we serve 74 communities, only 59 participated in the analysis. This is because we only link data about people from communities who opted in. So just because a community is part of our partnership doesn't mean that we get to just do whatever we want with their data. All communities have the right to self-determination and to decide for themselves, usually by way of a BCR or band council resolution, whether or not they'd like to participate. So we shared what we learned from this project in a few different ways. I'll talk more about the range of knowledge translation products and activities later, but one thing that everyone got was a report. And actually there were quite a few reports that were generated from this project. The maroon report you can see on the screen contains data from all of the communities who participated combined, and it's available on our website. I believe someone's also going to be sharing a link to the report in the chat. We also prepared reports for each individual partner with data from each of the communities they serve who decided to participate. Where possible, we also prepared reports for each of the communities who participated with just community level data. And finally, we also prepared what we called companion reports when possible, which show how communities across the partnership compared to each other for each of the variables we looked at in the main reports. And those reports, the companion reports are anonymized. So again, we're not sharing communities' data, even with each other, because it's not our data to share. They're anonymized. Each community is given a random number. That way we can compare while maintaining the privacy and respecting the autonomy of the individual communities. So another thing to emphasize is that those, the green, blue, and companion reports are not available to the public. They belong to those communities and partners, and only they can decide what to do with them. So some partners like the Winnebago Area Health Authority, which Loretta talked about, have their report on their website, but others have chosen not to share them, and they just use them internally. Again, this is about recognizing self-determination and respecting Indigenous data sovereignty. So today we're going to be drawing on findings from the partnership level report and its companion report. As mentioned, both are available on the website, and I believe the moderators, again, are going to make those links available. So before we jump into the findings, I just want to caution that we will be talking about mortality or death. Again, that was the focus of this project. This can be a hard topic for some folks and may bring up memories of loved ones who you've lost. We encourage you to care for yourself in whatever way works for you, whatever way is best for you. And if you're looking for someone to talk to, we do have some resources listed on this slide. I also want to preface the findings with this quote from Elder Hammond Laxall from Laxall First Nation. He shared this teaching with us at an in-person gathering we had when we were starting to try to interpret the data together. He did give us permission to share it with you all. We always try to include it before discussing the findings because it reminds us that, according to many Indigenous worldviews anyways, death is not the end of life. Death is just the end of our material life. And there is a part of our journey that still continues to happen after that. And we just hope that that's a comforting thought as we move through these findings. And again, may think about some loved ones who we've lost. So the first indicator we looked at was overall mortality. And between 1992 and 2014, there were over 5,000 deaths among Mamow Ahyamowen community members. This means that there were, for every 1,000 community members, there were around 110 deaths. And this rate is actually 1.5 times higher than the rate for Ontario overall. However, there was lots of variation. So when you break things down and look at community specific rates, you kind of get to understand this. And we'll show you what this looks like using a graph from that companion report. On the horizontal axis, you see a set of numbers. Again, each one represents a community who participated. On the vertical axis, you see the rate. So the number corresponding with the height of each bar is going to be your rate for every 1,000 community members. So when we add in these bars, you see what I mean about the variation, right? The community on the left with the lowest mortality rate comes in at just under 150 deaths for every 1,000 people or community members, while the community with the highest rate on the right comes in at just under 400. That's a pretty big difference. So the highest community has a rate that's more than twice that of the lowest community. And we just always want to drive home that point that even though there are similarities in terms of the communities that we serve and shared challenges, there's also lots of variation and they're all unique. The maroon bar is the average for all communities who participated, which was around 218 deaths for every 1,000 community members. And the yellow bar that is shown here is the Ontario average. So again, thinking back to that last slide, all of the Mamow Ahyamowen communities are above the yellow line, which means that they all had a higher mortality rate than Ontario overall, just kind of reinforcing that point. So now that we know about overall mortality, we want to zero in on premature deaths or those that happen before the age of 65. Sometimes the age of 75 is used as the cutoff for overall mortality, or sorry, not overall mortality, for premature mortality. But we actually found that this didn't accurately portray the folks in the communities that we served. It wasn't a meaningful measure because there were so many folks that were passing away before the age of 75. So premature mortality in this case is 65, and about 61% of all deaths in Mamow Ahyamowen communities were premature, so they happened before that age. This was much higher than in Ontario overall, where only 22% of the deaths were premature. And again, when we break things down by community, we see that all Mamow Ahyamowen communities, there was lots of variation between them, but we see that all of them were above the average for Ontario overall. Like I just mentioned, there's a pretty big disparity between these two populations. When we look at the graph, again, the community with the lowest percentage on the left side of premature deaths came in at around 41%, while the highest was over 80%. Again, that's almost double, right? So pretty big disparity between the two populations, but even within the population of folks that we serve, there's still a lot of variation. Every community is unique and deserves to be treated as such. There's also variation by sex. So men from Mamow Ahyamowen communities were slightly more likely to die before retirement age than women. This wasn't a huge difference, but it was discernible. However, again, just important to keep in mind that rates for both men and women in our communities were still higher than for their corresponding sex in Ontario overall. So while mortality rates give us important information, as you might be thinking, it's also helpful to know why people are passing away, because it's hard to take action unless we know what's actually happened and what's driving those deaths. So here we have a graph with the most common causes of death for Mamow Ahyamowen communities. We can see that injuries were the most common causes of death, followed by circulatory conditions, other conditions, cancers, and so on. But it can also be really helpful to know how these rates compare to Ontario overall. So we've added in that information on the left here. The yellow arrows and their size tells you a little bit about the cause of death, about causes of death that occurred at higher rates in the Mamow Ahyamowen communities compared to Ontario overall. So all but 2 of the conditions have those yellow arrows, which means all of those conditions with the yellow arrows impacted Mamow Ahyamowen communities at higher rates. So even though diabetes, for example, is only the 5th most common cause of death in Mamow Ahyamowen communities, the rate's actually much higher than for Ontario overall. And while we don't always want to be looking at things from a deficit kind of based lens by comparing ourselves to non-Indigenous population, this example shows how insightful these comparisons can be. Because you have, again, diabetes, only the 5th most common cause of death, but it occurs at 4.1 times the rate for Ontario overall. So if we didn't look at it from both perspectives, we would lose some of that insight there. Our partners and communities tell us that this information is helpful for them to include in things like proposals and so forth, and we'll talk a little bit more about that later. So I'm sure you'll agree, again, looking at cause of death was insightful, but it still doesn't provide us the complete picture of what's going on. And this is because the cause of death that's recorded on someone's death certificate doesn't always tell us everything we might need to know about that person's health. So for example, if somebody has diabetes and develops an ulcer that becomes infected, the cause of death listed on their death certificate might be an infection, even though that infection was actually caused by the person's diabetes. So to help with this, we looked at the chronic conditions people had when they passed away, even if they weren't the cause of death. So this graph shows how many chronic conditions people had when they passed away. You can see the number listed on the bottom there. On the left, we see that 12% of Mamow Ahyamowen community members had no chronic conditions when they died. Conversely, on the right, we see that 49% had 4 or more chronic conditions when they died, but that's compared to 65% of Ontarians, so it's a lower proportion. These two observations suggest that community members had fewer chronic diseases when they died compared to Ontario overall, which we actually found a bit confusing because it goes against some of the things we were just talking about, right? But when we were interpreting the data together with partners, we determined that it's likely because Mamow Ahyamowen communities, community members, not communities, are dying so much younger. This means that they don't actually get old enough to develop some of the chronic diseases that are common in older adults. So we also looked at specific chronic conditions that people had when they died. The conditions are arranged from least to most common for Mamow Ahyamowen community members from left to right. So on the far left, you can see that under 10% of community members had a history of rheumatoid arthritis when they died. This was the least common condition. And on the far right, the most common conditions were diabetes and high blood pressure. The red arrows signify conditions that were present, again, in a higher percentage of Mamow Ahyamowen community members who passed away compared to Ontario overall. Again, we broke things down by chronic condition and by community. So here, for example, we'll look at the variation in terms of people who passed away with a history of diabetes in each community. We did these for all the different conditions we looked at, and we also broke them down by sex and by age. That's, I think, beyond the scope of this presentation. If you'd like to check out that information, though, again, it's available in the full report. So when we look at this graph, we see a few communities actually had a relatively low percentage of people who died with a history of diabetes. They actually fall below that average for Ontario overall. You can see with the yellow line, while some of the communities on the right-hand side had more than double the percentage. So the point, again, that we're really trying to hammer home here is that there's lots of variation between communities. So we saw that in the previous slides. We're talking again about it now, and you're probably like, okay, Maureen, we get it, there's variation. But this is really important because often policymakers and even funders tend to take this kind of one-size-fits-all approach across really big geographic areas. But these graphs remind us that while we do experience these shared challenges and histories, all communities are unique and deserve to be treated as such. And I'll pass it off to Jen to talk a little bit about what these findings mean to us from another perspective.
So when we started to think about this work fairly early on, and there's actually been a lot of, it was very impactful to me, actually, as someone who, is pretty familiar with using large data sets and thinking about, answering for to guide evidence-based decision making and things like that. There was a really impactful time right near the beginning of the work and starting to see the results where elders and knowledge holders at the planning meeting were talking about how important the information is in a more spiritual way, talking about how learning about the ways that people passed away provides us with important lessons about how to live a good and healthy life. And to the people in the partnership and the people looking at the data, these are not data points. It's not. They're family members and loved ones and community members who have passed their ancestors. And so it was really an important framing from my perspective as someone, caring for and using the data and trying to communicate the data, is that through data, through these results, it's really a way accessing that knowledge of the ancestors. And so it was an important learning and something that grounded us early on and sort of carried through and has been has guided our thinking a little bit. And the other piece that sort of has guided our thinking is that, you know, the last thing that we want to be doing is using the data to shine a light on deficits and differences, and really continuing to support narratives of disparity. And so, especially when choosing a topic like mortality, we had to think carefully about making sure that we're not taking a deficit-based approach to the whole project, even though we are talking about, you know, sort of bad outcomes, really. And so one of the ways we've articulated that and thought about it is by saying we're not using this to shine a light on all of the disparities and deficits. What we're doing is using the data to shine a light kind of into the forest to find our next step forward, to find the path forward. And so it's a really important way of taking a strengths-based approach to an overall project, even though we have deficit based data, which is really a lot of the health administrative data does talk about deficits, but really it's about the spirit in which we're using it and the purpose that the partners have for looking at it.
Thanks, Jen. So now that we've gone through some of the high-level findings, we want to talk about how we shared those findings with partners and communities. It was really important for us to put a lot of time and effort into this knowledge sharing process because, again, we see this as their data. It is their data. So if we're not sharing it in a way that's meaningful and allows for them to use it, there's really not much point in doing this work. So in terms of knowledge products or physical products that actually communicate findings, we put together a few different things. So as mentioned many times now, we created several different types of reports. It was a lot of work, but very important. Equally important, though, was to create other kinds of knowledge products like slide decks, which we'll talk more about in a minute, and things like whiteboard videos that we hope will help share findings with a broader audience. So the reports were more for folks like health directors and chief and council, but whiteboard videos will probably be more accessible for community members, a lot of whom might not be interested in reading a 50+ page report, and we certainly can't blame them for that. As many of you may know, writing a report or putting together a slide deck often isn't enough to make sure that people actually engage with the data or do something with it. So we also wanted to engage different audiences in ways that would help partners and communities achieve their objectives. So the first step was to share the findings back with partners and communities because, again, the data belongs to them. This is where the slide decks came in, which we shared during interactive workshops and presentations. Again, just kind of breaking down those reports and helping people know how to interpret them. Even for myself, sometimes it can be a little bit overwhelming to look at the reports. So it was really important for us to help make sure that they were accessible. This process of doing workshops and presentations allowed people the opportunity to ask questions and to talk about what the results meant to them in the context of their lived experiences, which was also really important and helped make the data more meaningful. So some partners asked us to do things like press releases as well in order to help raise awareness about the health inequities that the analysis uncovered. We presented at academic conferences in order to reach audiences like researchers and public health professionals. And finally, the steering committee is currently considering if and how we might use social media to reach different audiences and share products like the infographics or whiteboard videos that I already talked about to help meet their objectives. So I'm going to hand it off to Loretta now to talk about what this means to her from her perspective as a steering committee member.
Thanks, Marie. So the next A few slides will take us to the perspective of Winnebago Area Health Authority. And in a moment, we'll talk about what other partners have done, and they know their work and their participation is quite critical because our self-determination as partners and steering committee members brings us together to enable our expressions of autonomy. In this aspect, this means getting where we need to go and supporting each other in that process and direction. So this data supports advocacy, decision-making, and ultimately self-determination that I mentioned earlier. Some partners and communities have used the varying levels of information from the analyses to support a successful Jordan's Principle application, revise their IRS registration process, support a successful long-term care proposal, inform priority age groups for COVID-19 vaccine rollout, provide orientation to new staff members, inform priority setting and program planning. So we'll look at the case of WAHA to help deepen the understanding. WAHA provides healthcare services to people living along the James Bay coast and Hudson Bay coast as well. We are situated at the southern tip of James Bay. Next slide, thank you. Winnebago is the Cree name that refers to the waterways that make up the traditional territory as Winnebago. The majority of people living in the region's coastal communities are Cree, or Innu, or Omishkego Cree. WAHA is comprised of hospitals located in Attawapiskat, Fort Albany, and Moose Factory. We have federal nursing stations located in Saskatchewan and Peawanuck. You'll notice that Peawanuck is the upper red dot along southern tip of Hudson Bay. We also have the Moosonee Health Center. So established in 2010 after the integration of the provincial James Bay General Hospital and the federal Winnebago Ahyamowen into the Winnebago Area Health Authority, or WAHA. It's also known as the Winnebago Health Authority Framework Agreement, or WAHIFA. So now I will pivot to some history of the hospital. In 1950, the Moose Factory General Hospital, or the Moose Factory Indian and Inuit Hospital, was constructed as a tuberculosis facility funded with federal government dollars, and it was built in the shape of the Cross of Lorraine. It was a 200-bed facility treating patients from as far away as the Northwest Territories and providing hospital services to the east and west coast of James and Hudson Bay. Over the years, the treatment of TB took on a very different treatment plan, and the hospitals were no longer required for that treatment. By 1966, the name of the hospital was changed, and in 1996, services were transferred from the federal government under Health Canada to and they received provincial funding, for the James Bay Ambulance Services, Winnebago Diabetes Health Education Program, and dental services, as well as the Community Mental Health Program. Next slide. Thank you. So here we take another closer look at Minnemathassowin Healthy Living, or the Public Health Department here at WAHA. It's a community developed and led public health model. We work towards supporting public health analysis and commitment towards meeting the needs of First Nation communities along the James Bay coast. One challenge in our work is that there is very little regional specific health data, which makes it hard for leaders to plan impactful community health programs. So in response to this, we've explored options for creating and sustaining partnerships with several organizations, including Mamow Ahyamowen, in order to provide leaders with the information they need to achieve health equity. WAHA, through the Minimum Ahyamowen Healthy Living Department, identifies public health priorities for implementation through health data collection and ongoing engagement with communities. For example, we continually engage with our health directors along the James Bay coast in order to identify what their needs could be. They communicate with us and we help provide the support. Minimum Ahyamowen also assists with community-driven research questions and participation. For example, some research projects might include the wastewater surveillance. Next slide. So the collaboration between Mamow Ahyamowen and Minimum Ahyamowen Public Health utilizes a community-driven, strength-based approach. The overarching goal is to translate data into meaningful information for communities. We also supported the Mamow Ahyamowen's engagement sessions with youth perspectives on data and research within First Nations communities. We responded to requests from community leaders regarding health concerns in community. The collaboration with Mamow Ahyamowen has been and continues to be an ongoing living initiative. We continue to learn how to adapt, respond to communities' needs and priorities, and develop sustainable relationships. For WAHA, there is a need for high levels of privacy and confidentiality when working with local data in small First Nation communities. So handling data discrepancies from multiple data sources and the importance of prioritizing local knowledge and data is key for us. The importance of ongoing and transparent communication to the public to build trust and credibility is also key to us. WAHA has been a hub for local communities to obtain their respective health data. The growing number of projects has resulted in a need for an expanded team. WAHA works on projects exploring the most pressing health issues identified by the communities. The results and information are shared back with the communities in a way that is impactful for health planning towards achieving health equity and decision-making. So more specifically, some of the ways that WAHA is using or use the findings from these two reports is that the findings were used to help bolster WAHA mental health proposal for enhanced services in the region. It was used in a WAHA nursing service proposal. It was used to help with the University Health Network project for remote heart monitoring. And again, this speaks to the importance of partnerships. It was also used for WAHA's COVID-19 CIHR grant with Queen's University. Once again, speaking to the importance of making partnerships sustainable. In addition to WAHA using the findings from these reports, such as with the University Health Network Medley project for heart monitoring led by Dr. Heather Ross from UHN's Peter Munk Cardiac Center. Their methodology applied Indigenous methodologies, such as sharing circles that were held in Moosonee and Moose Factory, and one-to-one interviews based on holistic and ethnographic approaches. The direct, key informant, in-depth interviews with some health directors in James Bay explored the perspectives and needs through generating research questions. The project will eventually expand up the coast. The findings from the Learning from Our Ancestors mortality experience of communities served by WAHA reports provided the UHN with context and understandings of our region, the people, and the common causes of death among our community members, and the different chronic conditions our people have. So in closing, the health information and James Bay Waha context is valuable. It provides helpful health information for healthcare providers, organizations, and communities to better understand the mortality patterns of patients in the region. In sharing this health information, our communities will use this data to further ask questions in order to guide research and data analysis in our area.
Thank you so much, Loretta. We just want to give a special thank you to you for taking the time to speak from a partner perspective about why we do this work. So, you know, the challenges that the partnership was formed to respond to, and about how the results are actually being used. Because again, as I mentioned earlier, there's really no point in doing the work if it's not going to be applied and if it's not going to be used by the partners that we serve and the communities as well. So Chimigwech, Loretta, for taking some time to walk us through that. So with that, we'll talk a little bit more about what's next. So partners have directed us to start 3 more analyses. We're going to focus on mental health and addictions, injuries, and chronic conditions. And again, like I mentioned earlier, the decision to look at these 3 areas was really based on some of the big findings that came out of the mortality report, or learning from our ancestors. So far, we've outlined exactly what we want to learn from these analyses and what we can learn with the data we have access to through ICES. We've completed the community opt-in process to figure out which communities want to participate and which ones don't. I think something like 70 out of the 78 communities that we serve have opted in, which is really exciting. We've also reached out to people who are experts in these areas, like technical experts, to help support the work. And a few months back, one of our partners held ceremony to help us start the analyses in a good way, which we were really, really grateful for. So we hope to get some of these initial findings back from the chronic conditions analysis by the end of the year. Eventually, we will be developing full reports, presentations, and other kind of knowledge products like the ones we talked about today. That will take some time though. So do stay tuned for that. We're really excited to see where this all leads us. And if you would like to keep in touch or stay up to date with the work, including the upcoming analyses, please feel free to sign up for our newsletter on our website. And yeah, with that, I will just say miigwech, thank you so much for having us, and pass it over to our moderators to see if there are any questions. Thanks.
Great, thanks so much, Maureen, and to Loretta and Jennifer. That was a great presentation. We do have a lot of questions that have come in, so I just invite you to, well, you've already all shared your video, we're good. So a lot of very specific data questions coming in. The first one is the number of Indigenous persons without status known, and how is this issue addressed in the data set? I'm not sure who would be best situated to speak to that one.
I can try. Hi. So we don't, I mean, there'd be ways of potentially trying to estimate that based on the number of people who maybe self-identify as First Nations, but we don't have the ability to estimate that. The only other sort of nuances that we can look at people who live in the First Nation community, but it may be like with an address in the community, but don't have, but aren't in the registry. But you know, essentially, these analyses are limited to status First Nations individuals for the purposes of this study, like for the project that we did together.
Great, thanks.
Thanks, Jen. And in that sort of direction, there's another somewhat related question that asked basically how, what is the definition of Indigenous used? First Nations, Métis, Inuit, and what as the variations between First Nations, Métis, Inuit within each marker and between?
Do you want me to answer that as well? So I can't see that one, but But I think that so essentially we're not using an Indigenous definition in the data part. Like we've talked about Indigenous data sovereignty, we've talked about sort of Indigenous principles at times, but in the data, we're talking about First Nations data only. And we're talking about data that are connected or sort of unlocked using the Indian register. So that we're limited to that for the purpose of the data project that we're talking about.
Okay, thanks. So which databases or sources from the ICES or CIHI contributed to the project? No, I'm not sure who best to direct this to, maybe Jennifer as well.
Sure, and there's a Christina, I believe there's like we can direct people to the part of the report where we also talk about this, but we are using the discharge abstract database, which is hospital data. It's a large part of it. We're also using the vital statistics and the mortality data, and we're using at times also the data from the OHIP database. So it's like the physician billing data. So I think that there's a full complete list in the report itself. And maybe I'll just, Christina, I can tell you might be looking for it now. So maybe Christina can share the link to that part.
Yeah, so I'll put a link to the report in the chat box again, but it's basically the appendices at the back of the report that talks a little bit about the indicators used, and most importantly, the limitations to the data that we sort of touched on a little bit before.
Yeah, and just to be clear, we only accessed data at ICES, so we did not access data at CIHI, but obviously there's some overlap in terms of the data sets that are available.
Okay, over to me. Well, this is a big question, and I will leave it to all of you to weigh in on if you like. Was racism identified as an indicator?
So maybe I can just start off with a bit of a story about how we've had these discussions, and maybe Jen can comment on this from a researcher, epidemiologist perspective. But this wasn't something we looked at as an indicator in the mortality report. It was something that came up a lot when we shared the findings with communities though. And so now we've come to use these discussions as a lens to interpret the findings. So we shared in this summer findings with one of our partners, and they brought it up right away, saying, well, when you're thinking about the chronic conditions that people have when they pass away, or even the cause of death, how do you know that's accurate? Because a lot of diagnoses or a lot of people go undiagnosed with certain conditions because either they don't want to go to the hospital at all, or when they go to the hospital, they're dismissed. They're assumed to be substance seeking or any other of the number of stereotypes that I'm sure all of you folks know about, or many of you folks anyways. So yeah, they came right out and said, how do we know this is accurate when we know that people aren't actually getting the care that they need and they're not getting the diagnoses that they need? And we just kind of said, absolutely, like, yes, that's really important. It's not something we measured, like I said, but it's now something that we use as a lens. So in that sense, we're actually going to be thinking of it more as a limitation to the work that we are doing in the future. And it's probably going to mean that a lot of our estimates are actually underestimates, which is true for other reasons related to limitations as well. But again, maybe I'll pass it on to Jen to talk a little bit more about that from an actual data scientist perspective.
Oh, no, that's great, Maureen. So what Maureen's referring to, I think, is sort of like how it would impact the data quality in a sense, because we'll see that, like, if you know, we know that there's racism in healthcare, and so it impacts people's access. It impacts whether they end up showing up in the data, and whether their diagnosis shows up in the data. So that's one way that racism could impact this project. But another important way of thinking about it is it's part of the roots. Like if we think about the determinants of health for Indigenous peoples, it's also a root of why there might be higher rates of chronic conditions, higher rates of injuries, and higher mortality rates. So it also is part of the story itself. And so I think that we don't have a racism indicator in data sets, but I agree that it's something we need to be contextualizing. And I think a lot of the questions that are in there around, like in the chat here around strengths-based, how do we make sure we're using things on strengths? How do we make sure we're understanding those roots? Like we're not just taking the mortality data and just looking at it on its own. It has to do with the way that the partners use the data and the reason they wanted the data. And it's not so much the full and complete story. We know that this mortality report doesn't tell the entire story, and it just has to be used for what it's as one piece of a really, really, really complex story. And I think that racism is one of those pieces where our data systems are not developed and complex enough, and maybe shouldn't even be trying to tell the story of racism in healthcare and how it and racism in general. But also but it's an important part of the story.
Certainly is. Yeah.
Thanks so much, everybody. So there's a question here about timeliness of the data. So how soon after data is entered into a system can you get access to the data? In other words, what is the time delay between captured events and access to the data for analyses? And there's a second part to that question, but which is basically asking, is there a goal to have real-time access to these to this data for clinical care purposes? So I'm not sure if who would like to take that one on.
I can start, and maybe Loretta, you might want to also say something. I'm not sure, but really long for using the data at ICS, it can be a year. Could be sometimes even longer between the time it's actually entered and then it goes through all its processing, and then the data is released to be able to be used for analysis after all of the all of the things that happen to the data. Like ICES is not a frontline place where data is used for decision making at a clinical level. So the ICS data can take a long time, but it's all coming from systems that come from a front line, that maybe come from EMRs or come from So I think the ultimate goal, like if I can recall back to those first meetings of the First Nations Center for Excellence in Epidemiology, people were talking about, we have all these community level systems that don't talk to other communities. So we can't, gather up our information all together. So we can only do it at a community level. So at a community level, those systems might be in place to be able to do that. Or at a clinical level, those systems might be able to be in place to do that, but not at a partnership level. I think that was part of the goal and hope, but I'm not sure, we actually turned to the ICS data as like it's better than nothing kind of thing. So I think that ultimately those goals are still there. Loretta, do you have something to add?
Sure. So yeah, I agree. The overarching goal is, again, to translate data into meaningful information for communities. So when it was time to get input from the communities in terms of participating in the analyses, the way they went about it was rightfully so, passing band council resolutions through chief and council, and then chief and council speaking directly with their own communities so that they had the autonomy to speak with their own communities. we were there, WAHA, we communicate with our health directors of each First Nation community. So, you know, we have Moe Quebec based in Moose Factory. We have Moose Factory, which is Moose Cree First Nation, Attawapiskat, Cache, Kashechewan, Pewanik. So it was really important for us to communicate with an open lens as well, to expedite in any way we can, to help with research projects. And in the WAHA context, we have our own research and ethics committee that we, you know, really try to pivot doing research with the communities in a good way, and that's transparent first and foremost.
Great. Thank you, Loretta and Jennifer. So I have a two-part question here from someone. So during the presentation, you mentioned that all the communities are unique and should be treated as such. So from a data perspective, you know, what does that look like in terms of the nuances of communities, and what do you potentially lose when you don't have comparable data across communities? And the second part of that question is just, you know, in terms of not having a deficits-based approach, has your team made any progress or anything that you're aware of about good asset-based indicators or strength-based indicators?
I'd be happy to start out and then ask if Jen and Loretta have anything to add, if that works, specifically in relation to the second question. So I think this idea around deficit-based data is one of the challenges of working with health administrative data, because that is, those data and frameworks and systems are set up from really colonial perspectives, right? And they are frameworks that do see health really as not as the absence of, as an absence of illness, rather than from a holistic perspective, right? So because we're focusing mainly on health administrative data, it really is challenging to use a strength-based approach and look at strength-based indicators. It might be possible, again, maybe that's a question for Jen. It's really her area of expertise. So maybe there is a way to kind of take a strength-based approach with health administrative data, but because of its nature and the way it's collected and the worldviews that kind of inform those systems, it would be really challenging, I think. That being said, in terms of primary data collection, which again is not our focus, but could be something that we'll explore in the future, whether it's collecting our own or trying to link to other data sets that might exist. The First Nations Information Governance Center does really important work through the Regional Health Survey and other important tools that, again, Jen might be able to talk more about. Internationally, there's some really cool work going on in places like Australia with projects like the My Kauai study that look at health from a more First Nations-based approach there and are using strength-based indicators to understand health as it relates to culture. Those are some examples that I'm aware of, but again, I think I'll hand it off to Loretta and Jen because they might have even more to add.
I don't have a lot to add, actually, Maureen. I think you summed that up pretty well. That you know, there are, like, you can choose to model strengths, but when you're modeling just the absence of something, is it actually a strength? Like, we thought about this a lot. You know, modeling the negative, like modeling not having, you know, modeling not dying early, or, you know, those they're really the interpretation becomes all convoluted in your head at times. But sometimes if you're sometimes you find a totally different story and you're shining the light down a totally different path. If you start modeling something that's not a deficit, you start thinking about things in a different way. So if you're modeling, you know, youth not smoking, or if you're modeling youth or you're modeling older people not having diabetes, then you are sort of thinking in a new way. But it is really challenging. And I think that a lot of times we are kind of when we are using these kinds of data, it's really about the stories that come from the use of the data and the reasons. Like, I don't think we need to be rigid about we can never model a deficit and we can never measure a deficit, because if we do, then we sometimes that's what communities, I mean, in this case, that's what people chose. People chose to look at mortality because it would teach us something. And that's a strengths-based way of using data. Like, because we want to learn and because we want to take steps. So I don't think we need to, the worst thing would be for us to be sort of patronizingly saying, oh, no, we shouldn't be doing that because that's a deficit. That's the steps that people want to take to find the paths forward. Then that's the data that's needed. It's about the use of it and the stories that's told with it.
Thanks.
Loretta, did you want to add anything to that?
Just very briefly, thank you. Just in response to land-based healing initiatives, and with this coming from a strength-based approach, as we involve youth, as we involve women, elders, children, looking in that context, I see that as a way moving forward, certainly, and also having more of the youth voice there would be good. Thank you.
And maybe I can just finish off with one thought that sparked from Jen's comment too, and a bit from Loretta's is there's a difference, I think, between there's something to be said for thinking about like these data sovereignty principles of who owns and who's using the data when we think about strength versus deficit versus asset or strength-based approaches as well. So the fact that we as Indigenous or First Nations community, I say we broadly, I'm a support person, but also from a community, but the fact that communities have ownership of and access to and all the other important things, their data as First Nations communities changes, I think, the narrative around strength versus deficit-based approaches, right? Because they're the ones who are in control of the data. So even though it might be a deficit-based indicator in some ways, them having the control over and ownership of that data means that they're actually in control of who sees it and what the message is when they share it, which is very different than, let's say, a non-Indigenous organization taking that data and creating a story about it, right? So when we're thinking about the difference between those two approaches, again, I think it's just important to go back to those ideas of Indigenous data sovereignty and governance and think about like how those play into the story. Thanks.
Thanks so much, Marie, and Jen and Loretta for your thoughts. So there's a question here that asks specifically about privacy and confidentiality policies, such as suppressing potentially identifiable information. And how do you determine what is potentially identifiable?
So I think that we probably relied mostly on the ICES policies for this. So there's lots of specific privacy and confidentiality policies. The one about suppressing small numbers because it's potentially identifiable. We use the sort of any kind of combination that makes a cell size less than 6, so 5 or fewer people. The data are suppressed, and then any any rows or columns that could be used to add those numbers up, we make sure that's for potentially identifiable information. That was sort of the rule of thumb, and that's the ICES policies. So we didn't have protocols that varied community to community. I think in large part, communities would prefer, even if we gave smaller numbers, it would be better. It would be better access to the data if we could give even smaller numbers, but we can't at ICES release those numbers. And so I would say on top of any sort of First Nations specific permission to access the data, I don't think there were any additional privacy and confidentiality policies on top of what ICES already has. Christina, do you think there was anything else that I'm missing?
I guess maybe just also kind of in line with what Maureen was talking about and how the principles of the partnership follow OCAP principles: ownership, control, access, and possession of the data. And so that also kind of goes in line with how the information was shared with communities and with partners.
Thanks. So that ties in well to another question we had here about ethics. So this individual's imagining that, you know, communities are able to provide input on the questions and the interpretations of the findings, and perhaps some elements of the research methods similar to participatory research. So what was the ethics approval process like for this project? And what special or unique elements were needed for REB members to learn and to kind of change their process?
That's a good question. We have sort of, if we're talking about like the pure REB kind of process, it was reviewed at the University of Toronto and approved at the University of Toronto for that particular project. And I don't believe there were special or unique elements for the REB. It's possible they had an Indigenous reviewer. I'm actually not sure. And otherwise, it was more the probably internal processes. Like there were a lot of layers to thinking about the ethics of doing this research that went beyond an ethics review. That I think were probably more key. So all the privacy, confidentiality, data governance stuff at ICS, all of the governance of information and sharing of information internally and externally in Mamow Ahyamowen. We thought about ethics a lot and held ourselves to a higher standard than the TCPS.
Thanks.
So there's another question here. Maureen, you kind of already answered this a little bit, but maybe it's worth going a little bit deeper. The data belongs to First Nations communities. However, do other health system players have access to the individual community reports for health system planning and integration in the North?
Yeah, that's a great question. So thanks to the person who asked it. The answer is not necessarily. So again, the communities own the reports, they own their reports. And so we as support staff don't have the authority to say, oh, well, this is this community's report, but we feel like it might be good for somebody else to know about, so we'll just share it. That's not the approach that we take. The community could share it if they chose to, and the same goes with the partner level stuff, right? The communities or partners are free to share it with whoever they wish, because again, the reports and the data belong to them, but it's not our place as support staff to make those decisions. We actually did have somebody reach out, I think from one of the LINs at one time. Christina likes to share this story, so I might not do it justice, but we had someone reach out and say, like, you know, this partnership level data looks great. We're so excited about what you're doing. It could be really helpful, which we were really grateful for, but they went on to ask, like, would we be able to get access to such and such, like some of the other levels of reporting? And we had to say, well, thank you so much. We're glad you feel it would be helpful, but that's something you're gonna actually have to approach the partner or community in question about. And it's kind of, it was really cool, I think. Again, Christina, correct me if I'm interpreting this incorrectly because I wasn't there at the time, but it was really cool because it was kind of like giving back the power to the communities and the partners in a way, because so often the situation is reversed, right? Like the organization like the LIN or someone else has that power. But in this case, it's very much not like that. And it was a very intentional move on our part to make sure that that was that was something we could promote. So anything else to add from that, Christina?
Nope, that's great. Thanks, Maureen.
Awesome.
Okay, so we have a few questions that are very specific to the causes of mortality that are included. So I'll just give you the two that I see here. So what kinds of things are included in injuries? And why is this such a high category for mortality? And the other question is looking at the other person is curious to hear about why rates of pre-existing chronic conditions are lower, but it seems that circulatory causes of mortality were disproportionately higher based on those charts that were provided.
Thanks. So Christina, I saw that you had answered that injury question a couple of times already. So
Okay, we'll take that one out of the queue then.
that's okay. It's just directing to the report. And do you want to answer it, Christina?
Yeah, sure. So I did provide a link to the full report that is available on the website for Mamow Ahyamowen. And although we sort of touch on the high level, if you go to page 9 of the full report, you'll see how injuries in particular were broken down. And as Maureen mentioned, we're going a little bit deeper into injuries in the next analysis. So that section will be, we'll take a deeper dive into that area a little bit more in the upcoming analysis.
And it maybe that's feedback for us that we need a slide that says what injuries, what we mean by injuries, because I think it was like three people asked that question. And then to the other person's question, I think it probably speaks to the okay, so to see the causes of death and the circulatory causes of death being quite high, that's from like the death certificate. To see what conditions a person had at the time of death, we're looking at the other data sets, right? Like the hospitalization data sets, the physician data sets, all of these data sets are going into which chronic conditions the person have at the time of their passing. It's a different data set. So the mortality data is going to be quite complete. There's going to be a cause of death, a person death certificate cause of death. All of the other data is going to depend on access to health care and the types of health care the person has access to, so like actual physical access to these systems, the impact of racism on both access and diagnosis. So it could be that people are not getting diagnosed, not having that access to be able to result in a diagnosis prior to the time when they pass. Or it could be that the data don't capture the places where they're getting their healthcare. So we do not have federal nursing stations. In many cases, we're a bit spotty on like the on-reserve services. And sometimes even the Indigenous specific models of care, like that would be delivered in Indigenous primary care kind of models. I think we have, it's like an indication of either a different type of primary care that people are receiving or like a lack of primary care.
Thank you.
Thanks so much, Jen. So we have time for just one more question, and it's really hard to choose one final question for today. But it has been asked a couple times in a couple different ways of, is there a group similar to this in Southern Ontario and or anywhere else across in any other province?
So maybe I can start off and Jen can add any more information or correct me, or Loretta. I know that the model that we kind of used to create the partnership, again, I use the term we loosely, this was the partners, not me, but they base it largely off a partnership that was similar in the eastern provinces. I believe it's called the Toucan partnership, but also I might be pronouncing that wrong. but they had done similar work prior to when we kind of started our work. Christina's put a link in the chat there. So yeah, that kind of founding background information was really, really helpful to the partnership when it first started up. And maybe I'll see if Jen or Loretta has anything to add about that.
I was also going to say the same thing, Maureen, that we're learning from others. And there's but I don't know about this sort of like this sort of partnership model and how it's evolved, and whether there's other similar things. Like I think really we're just learning from what had been done before in terms of the access to the data. Loretta?
Just to add, I think years ago, 2011 to 2018, possibly now, Cancer Care Ontario, the Indigenous Cancer Control Unit, has engaged with many First Nations level throughout Ontario. So we might want to look into Cancer Care Ontario and how it was also aligned with the Chiefs of Ontario.
Great, thank you. Well, on behalf of the Collaborating Center for Indigenous Health and everyone that joined us today, thank you so much for sharing your project and all the hard years of work that you've put into it. I'm just going to share my screen so people can see the link to the report and the link to the website as well. And you can also always follow up with the Collaborating Center, and we'll direct you to these resources. And yeah, with that, if you the webinar will be recorded, it'll be posted up on our website, and this is where you can access it. If you click on the QR link, it takes you to all of our new resources and mailing list. So thank you everyone today for joining us. We really appreciate it. Take care.